Hi, everybody. My name is Dale Shagrin. I'm with Care One Hospice here in the San Fernando Valley, and I'm here today to talk with you about something that most people put off talking about throughout most of their lives for understandable reasons. That's hospice and palliative services, and what it really is and what it really isn't. Hospice is basically comfort care. It's care that patients receive when they have a terminal diagnosis as defined by a life-limiting illness that, if it takes its normal course, will likely result in a person passing within 6 months or less. In order to get on hospice, a patient would need a referral from a physician that would enable them to get assessed by a hospice professional and determine if they qualify with a diagnosis, which could be one of many. The most prominent one, the most common one, is cancer, followed by many others, such as congestive heart failure, etc. But the point is that hospice is a choice. It's a choice for comfort over curative and aggressive treatment. What I'm mostly here today to do is to dispel some of the misconceptions that many people have about hospice and or palliative. Palliative is separate from hospice in terms of a program, so I'm going to address that less, but subsequent to the discussion about hospice. I'm going to start with the most common misconceptions that people have about hospice. And the first one would be, people believe that electing hospice means that they are giving up on their loved one. The reality of that is absolutely not. Hospice care may even result in a longer length of life than a person has if they don't go on hospice, assuming that they have an appropriate diagnosis and assessment that they actually qualify for hospice. Misconception number two, my loved one may receive hospice care per my sole decision. This is usually a family member that's saying that or asking that question, or a very close friend of the family that has durable power through an attorney. The reality is, no, a family member or any other durable power of attorney cannot unilaterally make a decision for a person to receive hospice care. In fact, you must have a doctor's order that has seen that patient and has a clinical knowledge of them prior to getting admitted to any hospice or to even being seen by a hospice. Misconception number three, what is the criteria to order hospice? People feel that there's criteria that is not actually appropriate criteria. So what it is, excuse the repeat a little bit, there must be a hospice diagnosis accompanied by a certification of terminal illness, otherwise known as a CTI, that a doctor must sign subsequent to referring hospice. So in that doctor's judgment, this person has that likelihood of passing in 6 months if the disease takes its normal course. Next misconception is, what are the most common hospice diagnoses? Most people feel that cancer is the only diagnosis that people come onto hospice for, or at least historically that's what they felt. The reality is there's dozens and dozens of appropriate diagnoses. Cancer still would be the most voluminous of the diagnoses that people have for coming onto hospice. However, people are on hospice for everything from congestive heart failure, kidney disease, what they call end-stage kidney disease, end-stage heart disease, ALS, many different, basically any organ that is at the end stage. End stage has to be empirically tested for. In other words, if you're a patient that's coming onto hospice for congestive heart failure, for instance, you'd have to be proven, it'd have to be shown that you have heart failure. Ejection fractionation rate, which shows how much your heart is working, would have to be below a certain percentage. You'd have to have be on oxygen, probably pretty much 24/7. Different parameters, COPD, chronic obstructive pulmonary disease, you'd have to be on oxygen full time for sure. You need more than just an opinion that you're likely to pass away in 6 months or less. But those are the most common diagnoses. Next question is, how much will hospice cost me? Most people feel that hospice, when I go to see the families, they feel that hospice is going to, somehow they're going to get billed for it and it's going to cost them. The reality is hospice is 100% covered by Medicare. Since 1974, when the U.S. adopted what had heretofore been already in effect in many other countries throughout Europe, after it was started in England in 1969, St. Christopher's being the first hospice, started by a lady by the name of Cicely Saunders. There was no cost. It was covered by the government. You've paid into it through Medicare. If a person is younger than 65, almost all private insurances will cover. If a person doesn't have money and they're on Medi-Cal, Medi-Cal will cover hospice. Generally, Medicare is the primary payment source for hospice, and a family will generally never receive any bill. So what does hospice cover? Hospice covers the following: a team of people that come to wherever the patient is, wherever they're living. That could be their home, that could be a skilled nursing facility, that could be a hospital, or any other place where that patient may be living. There are some standalone hospices, but not very many. The team consists of a physician who's the medical director, who probably will make an initial visit, but then transition to most visits being made by an RN, registered nurse case manager, who specializes in hospice. In addition to that, there'll be a CHHA, Certified Home Health Aide, a social worker of MSW level or higher, and a chaplain that can be of any denomination coming from more of a spiritual approach. Oftentimes that will be supplemented by volunteers that a hospice may have, because each hospice is required to have a volunteer program as well as a bereavement program. In addition to that, you could possibly have, as our hospice does, music therapy, pet therapy, etc. These different disciplines come together to create and envelop a patient and their family in compassionate comfort care. So the three principles, three words really, that you'll hear over and over again throughout a description of hospice will be comfort, dignity, and stability. Stability meaning that that patient will be able to stay at their home and receive treatment for symptoms as opposed to curative treatment, as opposed to going to an emergency situation such as a hospital, where they are expected to provide what they do, acute care or aggressive care. Hospice is not aggressive or acute care. It is symptom treatment or comfort care. We feel that that is a conduit for the second principle that I mentioned, dignity, because if a person is truly at the end portion of their life, the last thing that's going to reduce stress and enable them to feel better and therefore live each day to its fullest and therefore live with dignity is to have aggressive treatment. In other words, a patient will have one of the typical symptoms. Typical symptoms will be pain, digestive issues, or possibly respiratory issues. Those are probably the three most common. There's others, but those would probably be the three most common that we see. Instead of when a patient, let's say a patient has a respiratory problem, so they're breathing with much difficulty, they're starting to retain fluid, which is a common issue that happens when a person's body starts to basically function at less than its top capacity. They'll retain fluids. That'll make the breathing harder. We'll generally have oxygen in the house already because we supply all of the equipment and supplies and the medications, all covered. But the oxygen will be in place, and still the patient is not breathing well. We'll get a call maybe at 2 o'clock in the afternoon, maybe at 2 o'clock in the morning. We will come right there, as opposed to you having to call 911, which is what would probably happen otherwise, arrive at the home and provide whatever that patient needs to relieve the respiratory issues. We can do that. We are able to provide all of the medical treatments that are appropriate to treat a symptom, not cure it, but treat it. That often entails many different things: suction, oxygen, medications, nebulizers, handheld nebulizer to help the breathing passages open. We would do that at the home, and then we'd go home. We would do that quite unobtrusively and quite compassionately. as opposed to in an emergency setting where if you were to go for that same reason, a respiratory issue, they would automatically need to, per their mandatory protocol, hook a patient up to oxygen, an IV most likely, and blood testing would be done. All of the things that a patient in the latter portion of their life, especially as they get closer and closer to approaching what we call the active stage of dying, excuse the expression, doesn't want or doesn't benefit from. I've been in situations, I've seen probably close to 2,000 families and patients over the years, and I can't tell you how many times I've seen a situation where a patient has not initially gone with comfort care, stayed with aggressive care, hoping that they might get better. You end up in they end up in the hospital if they're truly hospice appropriate, and at the hospital they're strapped down, flailing their arms, really upset, and the family will say, or people will say, "Why is this patient so upset? My mom and dad has never been agitated in her or his life." And the answer is that they're saying they've come to a point where they realize that they no longer benefit from fighting this viscerally, physically, like they've done to this point. And they recognize on some subliminal level that they want to let go, but for reasons that are often emotional, are trying to continue fight on. That same person is expressing dissatisfaction, basically saying, "Leave me alone, let me be," and trying to, at the same time, appease family members who often are, for good intentions and good reasons, wanting them to keep fighting. So there's this balance. So I'm here to say that hospice and comfort care is being widely used. The increase in the numbers that it's being used are huge. I have some of them here, but I don't even really need to look at them. Since 1982, when there were approximately 25,000 patients on hospice, to 2014 or 15, there's now 1,800,000 people yearly being treated on hospice. There were originally in 1974 were approximately 1 or 2 hospices across the United States. Now there's over 6,000 hospices. People are understanding and being served by hospice and palliative. I just wanted to address some of the misconceptions so that if a person in your family needs or is dealing with an illness, that there's at least a possibility that this could be something that's not curable. And oftentimes that's testable through, if it's a cancer patient, for instance, the oncologist is going to tell you at some point. There's the chemo, the radiation, the drugs, whatever they're taking has stopped working. And I'm talking about after trying everything possible. We're not suggesting that you cut short any therapies. I'll walk away from a family when I come to see them to explain hospice if I feel they haven't exhausted every possibility to get good quality life for more time. None of us will be in favor of bringing on a patient like that are hospice professionals. People feel that they're going to lose their insurance benefits. You don't. You retain. Medicare Part A pays for hospice, the same as a hospitalization. The doctor's visits, medications that may not be covered through hospice are all covered through Medicare B and Medicare D, respectively, or private insurance. You don't lose those benefits. If a person is on antibiotics and those antibiotics are affecting a person's benefit and comfort level and well-being, we do not take people off antibiotics. Sometimes we'll even start a course of antibiotics if a person isn't close to the end and they have an infection that needs addressing, and will be comforted by doing antibiotics. There is any number of things we can do. We do use oxygen. We do use IVs if we need to. We have something called a CAD pump that a person can use at home that can pump medication in if a person's on things like morphine and drugs that are necessary to reduce pain and help the breathing systems. So I encourage you, if you have a family member or friend that's maybe at the point where they're not sure, but they're thinking that maybe aggressive care and curative care is exhausted, at least bring up this subject so they can consider it and have the option of getting comfort care instead of aggressive care when aggressive care isn't appropriate. Briefly to touch on palliative. Palliative literally means to reduce or relieve symptoms. Generally, we're talking about pain when we talk about palliative. Skirball, hospice inherently applies palliation. Any hospice applies palliation in their process of doing hospice. So, but now in our modern era, palliative is a separate program. There are separate programs that have generally branched out of hospices that are community-based and hospital-based, but they're two different things. So very briefly, a palliative program that is community-based generally consists of either a nurse practitioner or a doctor making occasional visits. Usually they're no more than once a week, 2 weeks, and more likely maybe once a month. Sometimes coinciding with the application of home health, which is a recuperative therapies that are done at home when a person has a skilled need that renders them homebound. Generally, if a person's on home health, they're probably not at the point where they're ready for hospice yet. But there are some circumstances where a person may still be pursuing a curative aggressive treatments and may still qualify, in other words, may have an end-stage illness that necessitates them getting more than just home health. So you can have palliative care with home health. Most of those would be basically a conduit or a precursor to hospice because it's still dealing with an end stage that statistically is probably going to result in the same longevity as a person on hospice, regardless. So there are community-based palliative programs that can supply, in essence, a lighter form of hospice without the other accompanying services. There are a couple of exceptions to that. There are a couple of institutions that can actually do a little bit more than just occasional visits by a nurse practitioner. But generally, if you take them as an aggregate, that's what most palliative consists of when it's community-based. It's occasional visits and guidance that allows a person to continue to receive aggressive treatments because they're not on hospice yet. They're not using the hospice Part A, so they can still go visit their doctor, which they can also do even on hospice. So palliative is really at a point where you're at a crossroads. There are some, when a hospital refers to palliative care, they're generally referring to an inpatient program where a person's at the very end stages and they'll get a palliative consult when a doctor feels that this person's going to be passing shortly. They end up going to some hospices contract for palliative care in a hospital setting or hospice care, and when they're in the hospital setting, they're basically at the very end, and we're helping them to achieve a comfortable death, to be realistic. That's generally what hospital palliative care really ends up being most of the time. That's all changing because there's a lot of grassroots efforts and even beyond grassroots efforts now to have a system that pays for palliative the same way that hospice is paid for. Basically under Part A, instead of being treated like it is now, palliative, which is as a doctor's visit. So you don't have the flexibility to do as many services because there's not reimbursement. But that's all changing. So there's a constant evolution. At any rate, these services are available for the benefit of the family and the patient. When a patient does come onto hospice, statistically, for an appropriate diagnosis, right now the figure I last saw was 31 days that they live longer, presumably because of less stress that they're going to get by being treated in a much less aggressive way and being able to be at home in their home environment. So while I'm a huge advocate for life and have always been the kind of person that is going to go the extra mile to get any extra time out of anybody that I work with or anybody, their family cares about them, that's what you're going to go for. But there comes a time when it is appropriate to get end-of-life care. And I hope that when that time comes, you'll consider hospice or palliative care. Thank you.